Module 3 Co-ordering Disorder Assignment and Treatment Opinion
Yes.
Option 3 type of program SUD treatment only programs refer client with COD to other program.
Which is the best program? Which is supposed to be the most effective program?
COD enhanced.
COD exchange program. Sorry. COD enhanced program.
Exactly. Very good. COD enhanced program is supposed to be most effective, isn't it?
Yes.
Yeah. Good. Thanks for that.
Thank you.
Can someone tell me what COD is? What does it mean? What does co-occurring disorder mean? Definition? Anyone? Any volunteers who would like to try defining co-occurring disorders? Any of our colleagues from Myanmar? Anyone who would like to give it a try? Co-occurring disorders, definition? Or Thailand, anyone? Well, I hear the definition, then we will carry on with what we are supposed to do today. I think those are very important things that has been repeated many times yesterday. Any volunteers? Give it a try.
I will do. They are any psychological or medical disorders that happen together with the SUD, but they are not causing each other, but they are occurring at the same time at the same person.
Wonderful, Dr. Chitsu. So this is independent, isn't it? So it's in a client with a substance use disorder who has either a medical or a mental health disorder happening at the same time, but they are independent of each other. So in short, that is what co-occurring disorders are. Very good. Okay, so thank you a lot. Okay, now what we're going to do today is we are going to go into the different mental disorders that we have, okay, that we normally see and treat. So in this, you're going to learn about some of the important categories of mental disorder, okay? Remember, as substance use disorder professionals, okay, or addiction professionals, you don't have to directly treat psychiatric disorders or mental health disorders. But I think what's important is for you to identify them. The problem is sometimes when they come in together, as in COD, it's so difficult to tease which is mental health and which is substance use symptoms. And that's not only something that you guys struggle with, even psychiatrists or mental health professionals cannot or find it difficult to tell. So that's the most important for you to recognize symptoms and be aware of what can be done. Right? So basically, due to that, as counselors in the substance use field, you're supposed to do some basic screening, some investigations, okay? Screening so that you know who is safe and who is not so safe, who can be kept at your place, who needs to be referred, you know, who may require what services. So I think these are basic competencies that each and every one of us should have. Now, some of the things which are important here is you got to engage, okay, very important to engage with a client. And if you think that engaging with a client with substance use is difficult, clients with COD can be double the more difficult. You also must know how to de-escalate, because there's a lot of emotional uproar or emotional state. Crisis, managing a crisis, when exactly to refer a client to a mental health facility if you don't already have one. And coordination, I think that case coordination is so important, okay? But of course, there are some limitations to this. It's not going to cover everything. It's going to be very brief. And on top of it, because of our time restriction, it's going to be even more brief than what we normally do, all right? Okay. Now, remember that when you're dealing with COD, I think this is something which is very standard. All of you already know. Active listening, reaffirming, identifying stage of change, involving client when you're planning for treatment, and of course, going at an appropriate pace, not your pace, but a pace that's comfortable with your clients, all right? So these are special consideration when you talk about them, All right, so let me ask you this as we step into this, okay? Now, all of you still have that thing from yesterday, yeah? So if you don't, this is what you have, poll everywhere, and you just type in polleb.com, stroke, and then Siva. Now, what do you understand as depression? I'm sure all of you have heard the word depression. So this is a word cloud. So I'll need you to type in. Okay. So some people have already started typing in difficulty in sleep. Yes. Eating problems. So we've got sleep, we've got eating. What else? What else do you recognize as depression? Right? Suicidal. Okay, that's good. Okay. Suicidal is one of the things that you're very afraid of when we talk about depression. Anything else? Hopelessness. Okay. All right. Okay, there's a lot here. The cloud is getting bigger. So disruptive problems, I think it's a lack of joyfulness, behavior changes, low socioeconomic issues, sleep issues, low mood, low esteem, eating problems. Yeah, so basically it's I see that everything is a problem here. Yeah, so that's a huge crowd. Okay, I'm going to lock the cloud so we can basically have a look at it. Yep. All right. So this is what you people have actually put in. So I see a lot of words here. I see a lot of words like social hopelessness, sleep, motivation, behavior, awakening, joyful, and these are all basically things which are low or it's a problem. Eating, disruption in life, mood, bored, suicidal. And I think you have hit the nail on the right spot. It's all the symptoms that you get in depression. And depression is something that is so very common nowadays. Okay. What is it? You have more than 350 million people in the world, okay, who have actually got depression. So it is a very common type of mood disorder that you actually find. Now, who gets depression? Anyone can, but it is genetically linked. So if you have parents or siblings who have depression, then you stand 1.5 to 3 times more chance to get a mood disorder yourself. Now, depression comes under something called mood disorder because it's mood, it's linked to mood. Okay, so it is very genetically linked. And there is a diagnostic criteria. Okay, so we always go by diagnostic criteria. Now, I'm going to share a diagnostic criteria from you. Now, this is only for your understanding and your learning purposes. So you don't have to memorize what I am putting up. Okay, just give me a minute. So what you see here, what I'm putting up is actually something that we use, okay, to refer. So you see, even psychiatrists don't memorize all these criterias. We know what the main criterias are, but we try not to memorize them. We try to understand them as they are, you know. Just a minute. Okay. Right. So this is major depressive disorder. Okay. This is the diagnostic criteria that you see. So 2 weeks. Okay. You're looking at 2 weeks period of either a depressed mood or a loss of interest. Remember, when you want to make a diagnosis of a major depressive disorder, all you have to do is these two questions. These are very important questions. You ask your client, have you had depressed mood? Or have you had a loss of interest or loss of pleasure? What you mean by loss of interest or loss of pleasure is, I don't enjoy the things I used to do. Like, for example, if I like to listen to music and now I don't like to listen to music anymore, that is loss of interest or pleasure. So these are the two major questions you are supposed to ask. Depressed mood or loss of interest and pleasure. And if they say yes, then you ask them how long. How long you having this depressed mood or this loss of interest. It must be at least 2 weeks. It must be either at least 2 weeks, nothing less than 2 weeks. If it's more than 2 weeks, okay. So I repeat again, 2 symptoms, either one. Either this, or even both. If both is more significant, and it must be there for 2 weeks. If they say yes to your questions, and if it's more for 2 weeks, then you have a high suspicion, high suspicion it might be major depression. Then you ask for these other symptoms, okay? So then you ask for sleep problems, like what you put. Now remember that in depression, the sleep is not only cannot sleep, but some people sleep more. Some people sleep more. Why they sleep more? Because they're so depressed, they don't want to wake up and go and see the world. So they sleep more. That is insomnia, lack of sleep, hypersomnia, too much sleep. Okay? Or you must also ask for agitation. That means they are very restless, cannot sit in one place, moving around, or retardation. That means not moving at all. So this is what you call as psychomotor. That means your body movement. Fatigue. very tired, feeling of wordlessness. Some of you put wordlessness there, very good, or some people can feel guilt, can't concentrate, can't make decisions. Simple decisions in life people can't make. And of course, recurrent thoughts of death, suicide. So these are the other symptoms that you can ask. These are the other symptoms that you can ask. But remember, these two are the main ones. If these two are not there, then you cannot say it's depression. Either depressed mood or loss of interest or both for 2 weeks. All right. So those are the symptoms when you talk about criteria for depression. And that must be there. That's very important. It must be there, a diagnostic criteria. Now, some of the causes for depression, okay? It could be biological, it could be environmental, or psychological factors. Now, let's talk one by one. Biological. When you use the word biological, that means you mean inside the body, okay? So it could be genetic factors. Like I said, if your parents have got depression, your chances of getting depression is very high. Early environmental effects on the developing brain. So if there is anything that damages or affects your brain as the brain is growing, then your chances of getting depression is high. Can someone just tell me from yesterday's talk, what are things that can affect an adolescent's brain while it's developing? Anyone?
Substance.
Exactly. You see what we learned yesterday and how we are connecting it today? And you see, that's the reason why we talked about it. Remember about how the substance can affect the developing brain. So this is where it comes in. So anyone who is affected or starts the substance early has got a higher risk of getting a mental health problem later on in life. And depression can be one of it. It could also be due to problems in childhood when the baby was born, and it could be a mixture of everything. That's biological factors. Environmental and psychological factors. Normally, it's trauma, such as abuse. There was something that I told all of you counselors there. When you see a young lady in addiction, what is that you must always ask for? Anyone? Whenever you see
History of sexual abuse.
exactly a history of abuse, see history of sexual abuse as a young child or as a young adolescent. Now that is an environmental and a psychological stressor. So this kind of early trauma can actually put people or make people vulnerable for depression later on in life. So you see how you're tying up, what you learned yesterday and what you're hearing today. So some other causes, it could be personal losses. Personal losses could be something like losing a spouse, losing someone close to you. It could be traumatic events even later in life. It doesn't need to be early in life. It can be later in life. Support system, family system, so important. Okay, when you don't have a support system, you are more prone for depression. Okay, financial. Nowadays in the COVID era, a lot of people have lost their job. A lot of people have been retrenched, and that's also another reason for depression setting in. So these are some of the reasons that you see, that can actually cause that. Now, it is common for people to present with depression when they're also intoxicated with alcohol or when they are withdrawing from a stimulant. So it doesn't need to be a major depressive disorder, but it presents with depressive symptoms. And that is where sometimes we get a bit confused. So monitoring is so important here. So you need to really monitor individuals to find out Why is the depression there? Is the depression there because of the substances, or is the depression there because of the mental health disorder? So you will find, and you got to look for whether the symptoms go away, you know. So if it's due to the alcohol, when you stop drinking alcohol, the depression should go away. If it's due to a withdrawal, when you withdraw after a period of time, and normally we look at least 1 month, the symptoms should go away. Now, let's say if it doesn't go away, if it's still there, then you understand that it must be a mental disorder. So you're looking at a co-occurring disorder. So remember, in co-occurring disorders, even if you stop the substance, the mental disorder symptoms don't stop. They carry on unless you treat them. Okay? So that is where that monitoring is so important in these cases. Now, there are two other ways how interaction may happen. People may use substances, when experiencing negative feelings. Like I told yesterday, when I really feel in depression, when people are really depressed, they go to alcohol. Why they do it is because some of the drugs make them feel better. So it numbs them. So alcohol, benzodiazepines work very well for that. All right. So that's the interaction that actually takes place when people are down with a mood disorder. Now, the danger about not recognizing depression, is it can complicate. And I think the worst complications that you have is suicide. Okay? Suicide can occur anytime. It can occur as early as in recovery. Suicide can also come back later on if you don't treat it well. So suicide is one of the most dangerous complications of depression if you don't treat depressions well. And of course, the other one is if you don't treat depression, you find that people will go back to the substances. So remember yesterday, I'm just linking what you learned yesterday. The best mode of treatment is not sequential, it's not parallel, it's integrated treatment. That means you're treating both the substance and the mental health problem at the same time, same place. That's the best. Otherwise one will turn back into others. So important for you to recognize depression, right? As we said, self-medication takes place very often. People self-medicate themselves in depression. Right? As I said, you find suicide quite often. All right. And I think it's quite common even where you are, isn't it? Why? And what do you understand suicide as? Why do people actually go and take decisions to take their life or to end their life? What are your thoughts on this? Want to die? Anything else? Liberation, suffering, hurting. Okay. Anything else? Yeah, many use poison. Yep. Yep, these are different methods. Okay. Yeah. All right. So I'm going to lock it here just to look at it. Can I just ask anyone who would like to talk? What are the most common methods of suicide where you practice? What do people do commonly?
And commonly it is hanging and poisoning.
And poison. You
Yes.
know what poison they use? We've got a huge forensic
And they usually use corrosive poison.
corrosive like organophosphorus,
And organophosphate sulfuric acid like.
sulfuric acid like. Okay. And where do these people live? I mean, how do they get these chemicals?
And they get the chemical from their work and from their surrounding.
Okay. Okay. All right. Good. Thanks for that. Thanks for sharing. Anyone else would like to share any other methods that's being used? Common.
Also on the gender.
Sorry.
Also depend on the gender difference. Women mostly choose or counting method.
Okay. Okay.
And
men?
And men use hanging method mostly.
That's a very good observation that you have actually brought up, that gender differences are there. Would you by any chance know why men and women use different methods?
Because afraid of pain.
Who? Men or women?
Pain.
Yeah, who is afraid of pain? The women or the men?
Woman.
Woman is afraid of pain. Okay. Okay. Yeah, I think that's a very good observation that you have. General research all over the world have also found the same thing that you have mentioned, that there is a difference between genders in the choice of suicide methods. And some of the reasons why they say men use more acute or more drastic methods like shooting, jumping, hanging, whereas the women use less drastic, like you said, poisoning, drowning. And some research have actually said it may be due to the hormonal differences that men and female have. The difference between the testosterone compared to the estrogen in men and female, the levels. They say that when testosterone levels are higher, we tend to do more aggressive things. That's basically one of the hypotheses of research. Very good methods. Okay. Anyone else wants to share about research? Around your experience in suicide, where you're practicing different methods.
Some use paracetamol.
Okay. Okay. And what age are these paracetamol?
Most of them are women.
Okay. What are their ages? How old?
Ages, yes. Mostly they are around 25.
Okay. Okay. All right. Do those paracetamol poisoning end up do they die, or are they managed to be saved?
Managed to be saved.
Okay. All right. And I think likewise, I too have experience with a lot of paracetamol poisoning. And normally we used to see it in a younger age. Ladies, yes, I agree also. In females, but younger age. Back where I practice, we see it among the teenage years, or maybe 18, 19, 20, around there. You know. Now, remember that there is two different things. You know, when you're actually talking about suicide, and you're talking about suicide. Real intention to kill yourself, there is something called para-suicide. PARASUIDI. SUICIDE, para-suicide. Now, para-suicide is people who attempt suicide, but they don't really mean to. That means they don't have the real intention. It's like a cry for help. That's para-suicide. People with suicide have got very clear intentions. Very clear intentions. All right? Yeah. So you find that suicide is very high, especially among substances. You find that statistics have shown when you talk about alcohol, 25 to 50%. 50 is a bit on the high side. Normally, we have seen the statistics of about 20%, 20 to 25% end their lives in suicide, people with alcohol. 10% of people with substance dependence, anything, commit suicide. So you find that there's a very close link between suicide and substance use and mental health. Very close link. Can I ask, since there is some interest in suicide among some of you, why is it that the rates of suicide is high in people who use substances? Any idea why? We got some forensic experts with us from Thailand. Would you have any idea why are the rates of suicide higher in people who use substances? Why? Anyone? Yeah?
Low serotonin level and dopamine level.
Okay. So you're answering it from the point of a neurotransmitter thing. Yes, that's true. It's true. But if I were to compare depression and suicide compared to someone who is depressed, taking alcohol and suicide, the second comparison, people who are drinking, people who are depressed and drinking, they commit suicide at a higher percentage. How does substances increase suicidal attempts? Any guesses?
Maybe the substances disturbs the decision-making skill.
Wonderful. And it's not maybe, it is yes, it does. What happens is a lot of the suicidal urges sometimes comes from the deeper part of the brain, but all ideas come to the front, which is called the frontal lobe, and this is the part of the brain that helps us decide or make decisions or judgment. Now, what alcohol does is it works on this front part of the brain or the frontal lobe and reduces your ability to make a proper decision. So people are very impatient, people act very irrational, and that is the reason why alcohol reduces your capacity to make a judgment, and that's the reason why a lot of attempt is there. Okay, so it's a very close tie, suicidality and COD. So whenever you see co-occurring disorders happening, it's because of the substance use, the mental health problem, and adding on to it a suicide urge. This is a very lethal combination, all three of this. So you got to be a bit careful when you see all these things. So identifying suicide urges in clients is so important. Never minimize it. When someone says, I feel like dying, don't laugh. Although he's telling you 2-3 times and he's not done it, don't tell him, you have told me 2-3 times, but you're still alive and you're not dead, and laugh at it. No, don't. Because eventually it will become serious and they will take their life. So be very careful about it. Okay? We have talked about this. Why substance and how they do it is basically substances can reduce or can worsen your depressive symptoms, okay, any substance, and it can increase your suicidal attempts. Another thing that we have to understand is when people take substances, it can reduce the effectiveness of your antidepressant medication. How? It's because the substances act on your body, and what it can do is it can affect how the medicine is broken down. So sometimes the medicines that you take are broken down faster, so their effectiveness becomes less. So there is an interaction between that, you know. One nice example is nicotine and antipsychotics. Nicotine can reduce your antipsychotic effectiveness. So that is why people who smoke, people with psychotic disorders who smoke, need medications at a higher level. So there is a interaction there, all right? So routinely look for all these things. Look for people who talk about suicide. Look for people who appears to be seriously suicidal. The most important risk factor for suicide is a past history of suicide. If you know the client who comes to your center has attempted suicide before, take it very seriously, because a past history of suicide is the highest risk factor for a future suicide. All right? Yeah, some screening that you must do, as what we have said, you know, look at that past history, look at the family history. Suicide, you know, surprisingly enough, is also genetically transmissible. So you find that if you have a high degree of high history of suicide in the family, it can also be transmitted through genetics. If you have history of availability to weapons or lethal weapons, you know, then you know they are very high risk. And that is why doctors are also high on the suicide list, because doctors have got accessibility to medication. You know, you can get medication very easily. So these are some of the assessments, you know. Ask about what is wrong, you know, why now, and talk about the plans. Talk about the plans. A lot of us are scared to ask for suicide because we think if we ask for suicide, people may get ideas. No, never be scared to ask, you know, never be scared to ask. A lot of people may have suicidal ideas, but most of them, almost 80 to 90%, are still deciding, what we call as contemplators. They don't know whether they should do or they should not do. So if you ask, you can actually stop their plans. Only a small 4 to 5% have decided, you know. So you must ask, do you have any plans? You know, do you feel like dying or killing yourself? You know, what are you planning? What do you think you should do? Ask about it, you know, ask about it. And that itself will actually start off that conversation. So always do a suicide assessment. Don't rub it off. All right. Now, there's something called a suicide safety plan. All right. Since it's on your slides in your book, I'll tell you what it is. But currently, evidence shows that suicide safety plans are not significant. Okay. What is a suicide safety plan? It's basically just a management plan. You know, that means an agreement between you and your client. You know, that means things like, you know, putting down some advices. Like, for example, if you have a strong urge, if you feel like killing yourself, the first thing you should do is call the doctor, call the emergency, you know, those kind of things. An agreement that nothing should be in the possession of your client, anything to commit suicide, And at the first sign of danger, the first sign of an urge, your client should call someone and go for help. This is what a safety or a risk management plan is. Okay, but sad to say, it's shown not to be as effective as we want it to be. All right. So monitoring should be there. So your place may or may not have proper suicide monitoring. So it must be almost 24 hours. And if you need a proper or a more intensive, then you need to refer clients to a proper psychiatric intervention place, especially those who have had very serious plans, previous attempts, people with very serious mental illness. So suicide is most very important. Okay. All right. Okay. Can I just stop here just for 1 or 2 minutes to ask, do you have any doubts around depression? Any doubts that you have around depression? Yeah, I would expect depression is something that's quite straightforward. And I think people see it a lot, people hear about it a lot, maybe not as much as this, something called bipolar. Yeah, so I think people have already started, okay, what do you understand by bipolar? It's something that's up and coming and people are learning more, people are talking more. You see a lot of movies made about bipolar, So there's a lot of advertisement out there about bipolar. So what do you all understand about bipolar? Okay. Oops. Think I lost that. All right. Okay. Yeah. Right. Okay. Yeah. Okay. Right. Okay. I'm going to lock this here because I've got the words that I'm looking for. Very good. Very nice. So the term itself, bipolar. Bi is two. Polar means poles. Like you have the Earth, you have North Pole, you have South Pole. Just like that. Bipolar is like North and South. North is up, very high. South is down, very low. So it's a condition where people cannot control their mood. So bipolar is also a mood disorder. The only difference between bipolar and depression is depression, you only see one pole. And that is why depression is also called unipolar depression. Unipolar depression. Now, bipolar, the difference is you have two poles. So you're seeing two sets of mood. So the mood goes up and down. So when the mood is up, it's very high. It's called mania. Mania is very high mood. You find that people get very irritable, people get very excited, very happy, and when they are too energetic, you find they get very aggressive. That's mania. So that's the high one. But when the mood drops down, then they can present just like depression, just like depression, just like what we spoke just now, all the depressive features, just the same. So it can either be up or it can be down, or it can fluctuate up and down, up and down, up and down. So that's bipolar. And that's why the depression that you find in a bipolar illness is called bipolar depression. So you have unipolar depression, that is only depression, and you have bipolar depression, where you can also have mania. Two different things. All right. So these are a different onset of disorders that you're seeing. And just to complicate things a bit more, there is a bipolar 1 and there's a bipolar 2. I'll explain in a while what they are, okay? But remember, when you say bipolar, you're seeing two different sets of moods, okay? It affects people at a younger age. So you normally see bipolar setting early as late teenage years, 18, 19, 20, okay? It goes on. Now, I'm just going to share the diagnostic criteria, okay? Now, I'm not going to talk about the depressive criteria because the depressive symptoms is exactly the same, like what you saw in depression. Now, I'm going to talk about the manic symptoms. So, right, should be here. Yeah. Okay. What is mania? Okay. Now, mania is a period of abnormal and persistently elevated, expensive, irritable mood, okay, which lasts for at least 1 week. So you find that the mood is high, okay, the mood is high. So if you want to know whether people have mania, you ask them whether they have had either high mood or irritable mood, okay, for at least 1 week. It should at least be for 1 week or more. The other symptoms of mania would be increased self-esteem or grandiosity. Grandiosity means I believe that I am very powerful, I'm very big, I'm very invincible, I can do a lot of things, that belief. A decreased need for sleep. In depression, the difference here, in depression, people want to sleep. Okay? People want to sleep, but they cannot sleep in depression. They just cannot sleep. In bipolar mania, people don't want to sleep. Why? Because they are so energetic, full of energy. They want to do a lot of things. So they feel like no point to sleep. Even if they sleep 1, 2, 3 hours, they feel they are already rested because there's so much of energy. So they are more talkative. They are thinking a lot. So in their brain, there is a lot of ideas that come in. This is called flight of ideas. So when you talk to them, they don't stop talking. They are talking here, talking there. They are jumping from one topic to another. And because they are so active, not only do they talk a lot or they think a lot, they are also very active in doing things. So you find that if you have someone with a bipolar illness, they will do many things, Like for example, if I'm at home, I will go and start painting the wall, then I will stop halfway. Then I'll go and wash the outside, then I'll stop. I'll go and wash the clothes, I'll stop. So you find that they're doing a lot of activities, but none of those activities they would have completed. All they will leave halfway because they don't have that patience to sit down and finish, because the energy is too much. When they have a new idea, they will jump. New idea, they will jump. So they're too active. So they do a lot of job, but never finish anything. So still a problem. And the other one is they get involved with very dangerous activities. Like, for example, because ideas are so much, they basically get involved with spending a lot of money, So what they will do is they will buy things which they don't need, or they buy too many things. Some people get involved with substances because the mood is so high. Some people get involved with sex and sexual behavior, which is high risk. And some people get into business investment, I've had a couple of my patients who actually, when they went into a manic phase, they got into a lot of business investment. So much so that one lady, she spent almost 10,000 Malaysian ringgit going and buying a lot of business opportunities because she had too many ideas in her mind and she couldn't. Later on, when the family found out, the family had to cancel all those things, but they never got their ideas back. I had another patient who was, when he was very manic, he was a Chinese Christian. Okay, when he was so manic, he got so many ideas. He went and changed his religion. He went to the Islamic department and he became a Muslim. He became a Muslim because he had lots of ideas that he wants to be this, want to be that. And when his family heard about it, the family was so angry. So the family brought, and I had to write a letter to the Islamic department. And luckily, the Islamic department was very understanding. They said that if he's making a decision to convert to a Muslim, when he cannot decide on a very rational mind, it is not counted. So they cancelled it. So thank God. So the things that they can do, because the ideas, so many ideas come in. In my experience, I've had people when during their manic phase, they have got married, second time, third time, they've started businesses, they've used drugs. So a lot of ideas come in. So it's very, very dangerous, and it makes your life disorganized, So you become very impulsive. So mania is as dangerous as depression, both extremes, The bad part is people in depression or mania do not agree that they have a problem. They are all in denial. So that's another huge problem that all of us have, okay? Now, bipolar 2 and bipolar 1. Now, these are two different things, okay? Now, in bipolar 1, okay, patients should have a manic episode. At least one manic episode. Whether they have a depression or not is not significant. But in bipolar 2, okay, they have something called as hypomania. So in bipolar 2, people should not have mania. If you have mania, you are bipolar 1. In bipolar 2, you can have something called hypomania. What is hypomania? Hypomania is like a baby. If this is mania, hypomania is like a baby mania. So hypomania is lesser, not as irritable, not as excited, not as angry as mania. It is lesser. If someone has mania, that person is very, very disruptive, very disorganized. And most probably people with mania need admission. They need admission because they are very aggressive. They would have caused a lot of problems, a lot of aggression. But people with hypomania sometimes can be treated as outpatient. How does hypomania feel? Hypomania is where people feel very excited. They feel as though they are very, very energetic, like they can do 1 week's work in 1 day. They don't sleep so much. They feel very active, very hardworking, can talk, can do the work better, but they can function without serious disruption in their life. So hypomania is still manageable as an outpatient, you know. So this is bipolar 2, hypomania and depression. But remember, some people ask, so you mean bipolar 2 is lesser in terms of damage to the person compared to bipolar 1? No. Both are similar because it affects the person. Whether you have bipolar 1 or bipolar 2, you are not functioning normal. Okay? So that's where it is said. Bipolar 1, yes, it can be severe and dangerous, but remember, bipolar 2 can also cause significant impairment. Why? The depression in bipolar 2 is longer. In bipolar 1, sometimes, most of the time, you find it's manic. So it's severe and dangerous, more irritable. In bipolar 2, although they have hypomania, they also have depression. And in bipolar 2, the depression is longer. So depression by itself will cause impairment in functioning. So that's why either bipolar 1 or 2, both are at risk or harm to the client. So that's how bipolar cycles are, you know. It's just like riding, those of you who have gone on a roller coaster, up and down. So when they go up, it's like a mania. When you go down, it's like depression, you know. Now, what's the connection between bipolar and SUD? You find that either bipolar 1 or bipolar 2, both mania and depression becomes more extreme, you know. And because of their symptoms, you know, when I'm manic, when I'm very high, I'm very excitable, I'm going out to the bar, I'm treating my friends, I'm drinking, you know, I'm using more drugs because I want to enjoy, because the mood is so high. When my mood is so low, depression, I feel very hurt, I feel very sad, and I use alcohol also, because not because I want to enjoy, but because I want to numb myself. I want to make myself calm. I want to forget my troubles. So either way, whether you are in mania or whether you're in depression, you're still using substances. Okay? And the problem is, the more substance you use, as I said, it makes the medication lesser effective. So it can go into something called as treatment resistance, and your outcome is also poorer. Your outcome is also poorer. All right. So the problem that we have as people who treat, okay, one is when a person comes into your center in intoxication, you know, or withdrawal, you don't know whether it's bipolar, or you don't know whether it is the drugs. Because when they come in intoxication, they are so restless, so aggressive. It looks like mania. When they come in withdrawal, they are so sad, they are so down, no power, no energy. You don't know whether it's depression. So it's very difficult to tease one from the other. So you got to wait and watch, you know. Like, for example, some other drugs like marijuana can affect the swings, you know. Stimulants can make mania worse. So there's a lot of mixture. What substances do is they try to mimic symptoms of mania and depression. So you got to wait and watch. So normally what we do is we let the substance go away, withdraw, and then we see, is the aggression still there? Is the depression still there? You know, and that's how we try to differentiate between COD and what we call as drug-induced. All right. So while you do that, keep a very close watch, okay, as to the relationship. And as you withdraw and as you're watching clients, be very intent about suicide, okay? Because suicide is very, very, very high, not only in depression, but also in mania, because they are very aggressive, very impulsive. Okay. Right, I'm going to stop here to see whether people got any questions. Do you have any questions on depression and bipolar?
Hello, sir.
Yes, Dr. Min?
Can mania cause homicide? Suicide action.
Can mania cause suicide? Homicide? What was your question, Dr. Min? Can mania cause?
Homicide.
Homicide. Yeah. Yes, it can. Yes, it can. Suicide is taking your own life. Homicide is taking someone else's life. So the problem in mania is at the heights of mania, when people are very excited, people are very impulsive, people with mania can also have psychotic symptoms, So during that time, some patients lose their ability to make this or judgment call. So yes, in that phase, we have seen people who actually kill others. I give you an example of a patient I saw in when I was working in the forensic wards, psychiatry forensic wards. So this man was in his 40s. So he had bipolar mania and he was under treatment. But what happened was he stopped his treatment. He defaulted his treatment and he started having his bipolar illness back, mania. And during mania, he started having a lot of grandiosity. He started having delusions, this psychotic symptom of grandiosity. He strongly believed that he was a very powerful healer and he could heal people, he could treat people. So he believed he was a traditional healer and he believed he could actually identify that where people were possessed by ghosts and he could actually treat them, And he started talking aloud, shouting, not going to work, He lived in the house with his wife, his sister-in-law, who was a very young girl. She was about 19, 20 years old, and a few other family. So one day, he didn't want to go for treatment and the family couldn't bring him. One day, the family went out, but the sister-in-law was alone. She's a 19-year-old girl. And so she started keeping away from him, because she was scared. He used to shout very loud. So each time she saw him, she ran away. And because he was having mania and psychotic delusions, he looked at her and he believed that she was possessed by a devil. So he ran after her to treat her, and his belief was to treat her, he has to have sex with her. So what he did was he caught her, he pushed her down, and he raped her. But while raping her, he held her down and he choked and killed her also. So he was charged not only for rape, but also for murder. So yes, it can happen. It can happen. So that's a very sad story, but yes. Any other doubts about depression and bipolar?
Dr. Siva?
Yeah.
This is Dr. Tin. And I wonder, in the slides of manic extremes, and the statements look very much like to me that it's happened in the celebrity, like make major changes to physical appearance or clothing style, engage in disorganized or bizarre activities, so that it is like a celebrity who always do something like that.
It's a good observation, Dr. Tin. Yes, well, you'd be surprised the number of people or the number of celebrities who actually have bipolar. Some people like bipolar hypomania because hypomania gives you a push to do things more than people. And the influence of substances, and you find a lot of celebrities use substances also, because that further pushes up that drive to do all those things. Yeah, it's not surprising that some of our celebrities do have underlying mental disorders, which they don't to treat 100% because they like those symptoms that give them that oomph or that push to do better than others, especially bipolar. A lot of our celebrities in the world basically have a little bit of bipolar because, you know, the bipolar people are the people who basically go out there and a bit more on the extreme in terms of acting, talking, performing, you know. So yes, good observation, most probably, but very sensitive, I would say. Any other, maybe one last question, anyone, about depression and bipolar?
Excuse me, Dr. Siwa.
Yes.
I'm Lalita, and I want to ask you a definition about like when people got bipolar and do the criminal.
Okay.
Yeah. So what is the difference between criminal psychiatric disorder, which maybe it is the one of the case?
Dr. Lalita, right?
Yeah.
Yeah. Can you please repeat that again? What's the difference between what psychiatric disorder?
When the people got manias and they do the aggressive behavior and then kill some people, so it is the one aspect of the criminal psychiatric disorder.
Criminal? Criminal, yeah.
Criminal.
Okay. And your question is you'd like to know?
Yeah, because when people cannot hold their behavior from the whatever hallucination or paranoid, so they do that.
Yeah.
Action or kill other, or try to hurt other or abuse other, which
Yeah.
is in the law or they will not say that illegal. They will be saved by the disease that when we write the medical certificate.
Yes.
This is the problem.
Yeah. Yeah. Normally what happens is, and I believe that it's the same all over the world. I think when someone commits a crime, this is forensic psychiatry. When someone commits a crime, we normally investigate whether or not that crime or that incident was done on a sane mind or an insane mind. That means what I mean is, was it done when he was under the influence of a psychiatric or a mental disease or not? So normally I think in most countries, I think all over the world, if there is enough evidence that the crime was done when the person was having mental symptoms, where he had no control over his decision because he was mentally ill, then they would normally be sentenced or charged to a psychiatric institution or a psychiatric hospital and not jail. Like, for example, the example that I just gave you just now, you know, of that man who killed his daughter, his sister-in-law. In Malaysia, if that man did not have bipolar and if he had killed this girl, that will be first-degree murder. And in Malaysia, it is death sentence. In Malaysia, it is death sentence. That means they will hang in the prison. But because we could prove that he had bipolar and during the time he was unwell and he couldn't think or decide, he was not sent to prison. He was sent to the hospital or the psychiatric forensic unit. And he spent a number of years in the unit. That was his punishment and his detention, his sort of sentence. So he was put in the hospital. And after a couple of years, he was actually released. He was actually released and he actually had a chance to go back home, you know. And that's normally there. So the most important thing is to identify at that point of time when the incident occurred, or at the time of alleged incident, was that person under the influence of psychiatric illness or not? And that can be used as a defense in court.
My last question, Professor Siva.
Yeah.
Is there any study in the world that determines the prevalence of methamphetamine use in homicide perpetrators?
Okay, I've got to say I'm not sure. I don't mind checking and letting you know. I'm not too sure, but I'm quite confident that they must have had at least something. I can check and let you know, no problem. The incidence of methamphetamine in homicides, isn't it?
Yes, Professor. But it's my hypothesis. I strongly believe that there must be some association between methamphetamine use and the homicide rate in Myanmar.
I'm sure there is. I'm sure, because I know that here, even back in my country, methamphetamine has been used in things like murder, theft, robbery, because it gives the people more energy, and it also blocks their judgment, so they don't think twice to kill. They just slash or shoot or stab. So yes, I'm not surprised that there is a huge role, but I don't have the numbers. I don't have the numbers. I'm quite sure your hypothesis is correct.
Yes, I have another point of view that, normally under normal circumstances, we are not courageous enough to kill a person. But when we want to do something, and then we would rather drink alcohol, because everybody feels that after taking alcohol, you become braver than before. So that I think maybe the drug addicts on their methamphetamine may commit homicide, but to kill another people, I think that the perpetrator would take an alcohol more often than the other stimulants.
You're right in a way. The reasoning behind it is because all of us have got something called anxiety, and that's what we are going to go into next. Anxiety. So there's a nice opening to the next topic. Okay. For whatever we do, we've got anxiety. Before I kill myself, I will think 2-3 times, and that's anxiety. Before I kill someone else, I will definitely think 2-3 times, and that's anxiety. What alcohol does, alcohol brings down your anxiety, and that's why people take alcohol even before they want to kill themselves. They take alcohol so that they become, like you said, brave. Anxiety comes down, I become brave. Yeah, explainable. Totally explainable. Thanks for those questions. Okay, I'm going to start with anxiety, and maybe about 10:45, then I will stop for a small break. Okay. Okay, so I'm going to talk about anxiety, and we'll learn about anxiety disorders. All right. So I go into anxiety disorders. Just like to ask all of you, what do you understand by anxiety disorders? Have you heard of them? Do you know any of them? Any type of anxiety? Why does it happen? Any thoughts on anxiety disorders? Why it actually happens? This is a word.
Professor, the poll is locked. We cannot answer.
Oh, sorry. Okay, my apologies. Sorry. Yeah. Okay. Now you will be able to. Now you can, right? Yeah. Okay. All right. Sorry, I didn't notice that. I had to activate it. So I thought, how come people got anxiety as soon as I was talking about anxiety? Right. Worry, afraid, situation, attack, panic attacks. Very good. Okay. Any other anxiety types of anxiety disorder that you know? One is panic. Somebody has written panic. Anything else that you know? Okay. Some people have written depression as a link to anxiety, which is a very good connection. Right. Okay. Much. Yes. I'm understanding much as it's too much than normal. Yes. Worry. Okay. All right. So I'm going to lock this now. Okay. Okay. So that's a nice cloud there. Okay. There's a nice cloud of words. You find that attacks, people have written attacks. Okay. And people have also written panic. Now, there is one type of anxiety disorder which is called a panic disorder, where you get a lot of panic attacks. We'll talk about that. Worry and anxiousness. There is one type of panic anxiety attack, anxiety disorder, where you have a lot of worry and anxiety, and that's called generalized anxiety disorder. Now, some people have written situation and specific. Yeah, some people only get anxious in certain specific situations, like when I go in a crowd, when I go into a social setting, and that's called social anxiety disorder. So these are things that we are going to talk about. Okay. So anxiety, okay, becomes a problem when it starts interfering with your daily function. All of us have anxiety. Remember yesterday when I asked you all, are you afraid of cockroaches? And nobody put up the hand, which I think is a bluff, because I'm sure everyone is frightened of cockroach. When I ask my students, they are all afraid of cockroaches, especially the cockroach that flies. You know, you have the flying cockroach. Why? Because the flying cockroach, you cannot predict. You know, you don't know where it's going to fly. So people are more scared of it. But that's not a disorder, because it doesn't stop them from going to classes, from going out with friends. But when your anxiety becomes too much, just like what the cloud said just now, you know, too much, you know, when it's too much anxiety, then it starts interfering with your function. And when you cannot control it, and even more, when the anxiety comes for no reason, you know, so it can stop you from going to school, from working, from functioning in the community, or even at home. And then it's called anxiety disorder. Okay. Remember, when we use the word disorder, it means your functioning is affected. If you have anxiety and your functioning is not affected, it's not a disorder. All right. So it can cause harmful effects, you know, when anxiety is extreme, very harmful. It can stop you from thinking properly. It can affect your emotional well-being, your physical well-being. All right. So as I said, it can be harmful if it occurs for too long. And many of you, you know, in that cloud have also placed, the word, where was it? Depression. Okay. So some of you will be thinking, what has got anxiety got to do with depression? when anxiety is there for too long, when you don't go for treatment, it starts affecting people and people get very frustrated. So you find that long-standing anxiety can lead to depression. There is a small link between anxiety and depression. So every time, this is another take-home message, just like what I said about young girls in addiction. Every time you see someone with depression, always ask for anxiety symptoms also, because they're always parcel, hand in hand. They come it's like a gift package. You get one, the other one comes free. Okay. So anxiety is quite high, although it states 3.6%, but you must understand that 3.6% is actually quite high in the world. So we are going to talk about 3 types of anxiety: panic, social anxiety, also called social phobia, and GAD, generalized anxiety disorder. Now, let's talk about panic disorder. Now, panic disorder, as the word says, it's, all of you know what is panic. So panic disorder is characterized by unexpected, recurrent panic attacks. So it is very sudden and the person feels very problematic, because the feeling that a person gets is as though he or she is going to die. So what do they experience? Some of the very serious panic attacks, they experience the heart pounding fast, they can't breathe, their hands start to shiver, they feel very dizzy, they can't breathe well. It's like having a heart attack, And they have this fear that something bad is going to happen. Most of them will tell you, I thought I was going to die. That is how strong a panic attack can come. And the magic thing is, it only lasts for a short period of time, normally about half an hour, or even shorter than that, a few minutes. But even in that few minutes, it is so intense that people feel they're going to die. People feel that they're going to lose control. Now, let's have a look at some of the criteria for a panic attack. Okay. Just give me a minute. Okay. So what you're looking at is the book that I'm using is a DSM, okay, a DSM-5. So this is a huge book. So those of you who have it will know what I'm looking through. It's like the Bible for psychiatry. So we only check when we want to teach or when we want to refer or research. It's just sitting there in the office. So let me just go to panic disorder. Phobia. Social. Okay, panic disorder. So these are examples of panic symptoms. Okay, these are examples of panic symptoms or panic attacks. So a panic attack can come in many, many forms. So what you see there, things like palpitation, sweating, trembling, shortness of breath, choking, chest pain, nausea, dizziness, chills. That means you feel very hot and cold, numbness, derealization, and fear of losing control or fear of dying. So all these things, sometimes when you get this, it feels exactly as though you're having a heart attack. But, it's normally what the diagnosis here is, it's a persistent concern about having attacks. And because of that, it must go on for at least 1 month or more. And there are a lot of changes that takes place in their behavior. I'll give you an example of some of my patients that I have. I had one patient, because of his panic attack, he makes sure, when he comes to a hospital, every time he has an attack, he comes to the hospital, he runs to the hospital because he thinks he's going to die, And as soon as he enters the hospital, he's already very relaxed. So even the doctor can come and see him, he's already sitting down very relaxed. Just entering the hospital, because when he enters the hospital, he knows, safe, I have doctors. Whatever happened, the doctor will save me. So what he has done is, he has bought a house very close to the hospital. So each time he runs to the hospital. In 1 month, before he started on treatment, in 1 month, he has come to the hospital more than 15 times. Emergency. So much so when the doctors see him itself, they know, this fella, they get tired when they see him, at the emergency. Because he runs in so very often. That's as bad as it is. I have another patient. Before his treatment, he was so scared he was going to die that he never stayed at home. He parked his car outside the hospital. He slept there, until he could start on treatment and he got better. Because he was afraid, if I go back home, I cannot travel to the hospital fast. I may die. So this is how strong it can actually be, this kind of panic attacks. But they know that, eventually nobody dies. But the fear, it is so huge that it sort of affects them and affects their functioning. So because of that, they can't work, okay? They can't work, they can't function. Now, certain substances basically increase panic attacks. Like, for example, caffeine, coffee, or other stimulants, even tea sometimes, can trigger a panic attack. So that is why people with panic disorder, we always advise them, reduce your coffee or your tea because it can make your panic attacks worse. So, though as I've been saying, the panic attacks are very sudden. So if I'm going to draw a graph, it goes up and then it comes down very fast. So it starts very sudden, but sometimes it lasts just for a short while. It reaches a peak in 10 minutes and then it comes down. But the feeling is, when you get that, the person feels that he's going to die. So they start calling their wife, they start calling their children, saying, bye-bye, I'm going to die, you're not going to see me. And after a few minutes, they're okay. The next time they get it, they have that same fear because it's so fearful, okay? It is so fearful. That's panic attack or panic disorder. Now, moving on to social phobia, all right? So, social phobia or social anxiety disorder is another type of anxiety. But panic attacks or panic disorders can happen anywhere. But people with social phobia or social anxiety disorder, the anxiety only comes in a social situation. That means when I am standing in front of a crowd, when I'm standing in front presenting something, when I'm talking or presenting something, like now I'm presenting to all of you. So if I had social anxiety, when I see all your faces, I will start feeling very anxious, So these are some of the examples of a social situation, like eating food, attending large parties, speaking to people, even using a public restroom, So the difference between social anxiety and panic disorder is panic disorder, their fear or people are scared that they are going to die when they get it. But in panic in social anxiety, the fear is not about dying, okay? The fear is that he or she may be humiliated, embarrassed, maybe laughed at, or negatively evaluated in front of people. That's their fear. So when they stand in front of a crowd, even before they can present, in their mind, it's going on. Will they laugh at me? Am I going to make a mistake? Will people laugh at me? People look at me. So what they do is they look at people. They look at people. Just like I'm talking to you all now. If I had social phobia, I'll be looking at you and seeing, oh, is this fella laughing or not? And then if they laugh, then I'll feel very scared, all those things. So their fear, social anxiety, is not about dying. Their fear here is that people will laugh at them, that they will make mistakes. So what happened is they avoid this kind of situation. So whenever there's a meeting, I always take my leave. I go away. Whenever presenting, I try to run away, those kind of things. So they're always feared of social situation. So they try to avoid it as much as they can, okay? So that's social anxiety disorder or social phobia. You find that demographic studies have shown that women are slightly more at risk than men, okay? 3 to 13% of the population. It's quite high, actually. In my practice, I've seen a lot of students. Who have social phobia, who really have social phobia. At presentations, they start to tremor, so they don't do well in exams because each time they have exams and then they have this fear, that am I going to make a mistake? Are people going to laugh at me? Those kinds of things. So they carry on with life. So the third type of anxiety disorder, okay, we have covered panic, social phobia. The third common one is something called GAD or Generalized Anxiety Disorder. Now, here, in Generalized Anxiety Disorder, what is their worry? Their worry is not about making a mistake or people laughing at them. Their worry is not about having a heart attack or dying, but, the word itself, generalize. So these people are worried about everything, simple things in life. So what they have, they have a lot of worry, simple things. I give you an example. When the husband leaves the house, they start worrying. Oh, is my husband going to work? Will he meet with an accident? Is he going to see another lady? And my kids go out to school. Are my kids going to be safe? So I worry about everything. These people, they know that these are very simple things that they shouldn't worry, but they can't stop themselves. They just worry. So they're also called worriers. So they not just worry about one thing, they worry about multiple things. And that is what makes generalized anxiety disorder a bit more difficult to treat. It can be worrying about family, about finance, work, school, a lot of things. So when you look at generalized anxiety disorder, it is, as the term says, it is more general. Panic disorder is very specific to panic symptoms. Social anxiety is very general, very specific to social surroundings. Can I submit it? But generalized anxiety disorder is very general anxiety about most everything. Let me just get that. Yep. So it's excessive anxiety and worry, at least 6 months. Okay. And it's about a lot of things. They cannot control the worry. So they feel very anxious. But when they are anxious in GAD, this is what they feel. restless, easily tired, cannot concentrate, irritable, muscle tension, sleep disturbance. When you look at these symptoms that people with generalized anxiety have, and you compare just now when I showed you panic disorder, you find that the panic disorder symptoms are very high. Like I can't breathe, I feel tremors, I feel chest pain, This one is a bit lower. So if you're seeing symptoms, panic disorder is very high symptoms, but short period. GAD is low symptoms, but very long. Sometimes they worry throughout the day. They worry throughout the day. There's another term that I'd like to bring to your knowledge, since we just passed it, is something called agoraphobia. Now, agoraphobia is also anxiety. What is it? It is the anxiety about being in a place where help or escape is not possible. So it might be a crowded place, or it might be a very close place, or it might be an empty place. But the fear in agoraphobia is that if I get a panic attack, I cannot escape or get help. Places like buses. You have buses in Thailand and Myanmar. You know how crowded the buses is? Just imagine if you're getting a panic attack in the bus. Even to get out is so difficult. Being in open spaces, being in enclosed spaces like shops, theater, in a crowd, being at home. So that's agoraphobia. Sometimes agoraphobia occurs with panic disorder together. All right. So let me just finish this up, then we will actually take a short break, right? Now, so panic disorder, the thing is the fear of losing control or dying. Number 2, social anxiety disorder, the fear of making a fool of myself and people laughing at me. And the third, generalized anxiety disorder, consistent worries about everything. Now, all these things are very related to substance use, because some substances can make your anxiety high. Like, for example, stimulants. The word stimulant, it stimulates your mind. So obviously, it makes you more anxious. So when people use substances, it makes anxiety worse. And sometimes we treat anxiety disorders with anti-anxiety medication. There are some medications which we give to calm them down, things like benzodiazepines. A very common one is called alprazolam. I don't know what you call it in Thailand and Myanmar. We call it Xanax or alprazolam. Now, it's a benzodiazepine, but when you have an SUD problem, you find that people start abusing this. So, it is addictive. It is addictive. And when they stop, they have withdrawals, and it looks like anxiety. It looks like anxiety. Sometimes when you use stimulants, your anxiety gets high, and it can also lead to aggressiveness. There is something called paradoxical symptoms when you abuse benzo. What paradoxical symptoms mean is, the word paradoxical means opposite. So by right, when we give benzodiazepine are sleeping tablets or relaxing tablets. People are supposed to relax. But in certain people, when you give benzodiazepines, instead of relaxing, they become more aggressive. Paradoxical. I had an experience once. I had a patient who had an SUD. He was an opiate dependent person admitted to our wards, and we sedated him with a benzodiazepine. At that time, we gave him Domicum just to calm him down. And after he took the Domicum, instead of calming down, he got more aggressive. And what he did was he jumped on the bed, he pulled up the light, the fluorescent light, he broke it, and then he threatened to kill himself if we don't send him back. And he became very aggressive. So that was my first experience of a paradoxical symptom, So it can happen, sometimes with benzo. Not every time, certain people. So some relationships that you have, between this and that, SUD and anxiety is some substances like marijuana can reduce anxiety, so it calms down. The problem is it masks some of these drugs can worsen or mimic your symptoms, and some drug, it can mask symptoms. So you don't see it, you don't see it until you stop the substances, then you can see the symptoms. So that is why I was trying to say right from the start, substance use and mental disorder, they sort of mask each other. So you don't know which is which. You got to take off one by one, then only you see what's underneath, and that's a very careful work that one has to happen. So remember, this is what I'm trying to say. When you withdraw, you can see a lot of strong anxiety. And when you take some kind of stimulants, you can see increase in anxiety. So you got to watch out for that. All right. Okay. Yep. All right. So I'm going to just stop here. I'm just going to stop here. 1-2 minutes just to any doubts on the anxiety disorders before we take a break. Any doubts that you have?
Hi, Professor Siva. I once learned agoraphobia is the pathologic fear of open spaces.
You're right. You're not wrong. You're correct, but not entirely. Agoraphobia is open spaces is part of agoraphobia, but agoraphobia is technically the fear of being in space, either enclosed or open, where it's not about the space, it's about the fear of not being able to escape or get help in time. So it's not about the place. So it's not about the place at all. So it can be open spaces or it can even be crowded places, but it's all about your fear that you may not get help in time and you might die or something might happen. That's the agoraphobia. That's the fear. So you're correct, Dr. Aka, that yes, open spaces, but also in crowded places.
Thank you, Professor.
Dr. Siva, for the social phobia, how is it different from xenophobia?
Okay, what do you understand by xenophobia, Dr. Tin?
Afraid of strangers.
Yeah. And what is the reason that you're afraid of strangers?
I assume that we cannot differentiate between friend or foe.
Yes. So, in xenophobia is a type of phobia or prejudice, against people or certain people. So you don't know whether to trust them or not. So the entire understanding behind that phobia is based on trust. Whereas in social anxiety disorder or social phobia, the fear is of being scrutinized or being laughed at or being made fun of. So it's phobias, but the reason behind phobias are different. And that's how it basically means differently. Sometimes xenophobia could also be identified as a dislike or prejudice, about people from different countries. That's also one of the classification of xenophobia. So it's not exactly the phobia, but it's why it's there. So in social phobia, the reason why social phobia happens is the fear that they may be scrutinized or laughed at. That's the entire thing.
Yes, my second concern is that I think a year ago, some guy in Europe, he tried to stab with the dagger, with the knife, and run around the place and stab with the knife. So then it's some people say that he got a panic attack, and some people say that it is like a running amok. What kind of thing is that?
Okay. Right. I think there are two ways. Now you brought up two different entities. One is amok, 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 or running amok. It's a dissociative kind of phenomena, and the other entity is a panic attack. Now, sometimes it can happen in a panic attack. With panic attack, many of them experience something which is called derealization. There is a word called derealization. So, in a panic attack, which is very severe, they find that everything in the world has changed. They see the world as it is, but they feel like everything, it looks different. And during that time, they get very tensed up and they can do things beyond their control. But they are aware. They can remember what happened, so they can tell you. Whereas in an amok is also an anxiety presentation in certain countries, especially in the Asian region. It is described as a person who is living a normal life suddenly gets an anxiety. He doesn't know what he's doing. He runs around, and it's described as he takes a weapon, he runs around and he harms people, hits people, breaks things, harms people. And at the end of it, he faints. He faints, or he loses consciousness. And when he wakes up, he can't remember. He can't remember. Dissociative. It's a dissociative disorder. So I think the biggest difference between one and the other is in amok, it's because it's a dissociative disorder, you won't be able to remember what happened during that period of time. Whereas in a panic disorder with derealization and anything, the person will be able to relate what happened. So I think that's one of the major differences.
Thank you. Thank you, doctor.
Okay, I think we will go into a short 15-minute break. Okay, so my time says it's 10:50 Thailand. Okay, so let's come back at 11:05. So we take a small break. We return at 11:05 a.m. This is Thai time. Okay? Go stretch, go walk around, take a short break. I'll see you at 11:05. Thank you. All right. Okay, shall we start? All right. Okay. Before I start, I think Dr. Lalita had asked minimum dose of caffeine intake that could trigger panic. And is it individualized? Yeah, generally it is individualized. Yes, doses above 200 is said to be a danger. Okay, above 200 is said to be danger. Although there were some studies which basically says around 400 milligrams per day of caffeine is called harmful. So it's a range, and I think it's very, very individualized. But how many cups it sort of comes down to, I'm really not too sure. So those of you caffeine or coffee enthusiasts, among yourselves, go do your calculations and see how many cup of coffee does it come up to actually, 200 milligrams. All right. Okay. Let's begin. Okay. Let's start with respect to time. So we're finishing up something else that is called post-traumatic stress disorder. Okay. Now, post-traumatic stress disorder used to be under the anxiety spectrum, but of late, because of the incidences of cases that we have seen, it's basically been given its own group, a trauma-related group under the DSM-5. So it stands alone by itself, post-traumatic stress disorder, as a group. Under it comes acute stress disorder and other things. What do you understand about post-traumatic stress disorder, and do you see it where you come from? Do you see it in Thailand or Myanmar? And how do you see it? What kind of presentations do you see? Maybe if you can share a bit on the word cloud, and let's have a look. Anyone else? Anyone wants to share on post-traumatic stress disorder? No? People are not too sure about it. Experience, bad situation. Yeah. First hand, second hand experience. Interesting. Right. Okay. I'm going to lock this just to look at it. Right. Yeah. I think what most people have written in is how experience affects your emotions. And some people have actually written about soldiers. That's where it actually started off, PTSD. It started off being observed in the soldiers who have come back from the Vietnam War, the US soldiers, and despite coming back to the States, they were still experiencing the war. And that's where the term PTSD was coined and started developing. But now, as we know, you don't have to be a soldier to experience PTSD. It can be any form of trauma. And trauma depends on how you emotionally understand your experience. So that traumatic event can either be first-hand or it can also be secondhand actually. So there are different understanding of PTSD at this point of time. So as I said, it used to be under anxiety because PTSD has got lots of anxiety symptoms. But at the moment, it's an altogether new chapter in the DSM. All right. So in post-traumatic, you find that there's a lot of re-experiencing of the symptom that takes place. So when you look at the definition or the DSM criteria post-traumatic, you find that it says older than 6 years, okay? You can get it for 6 years and below, but it's a different criteria. So for adults and bigger children, there are a few things. One is you must have exposure to actual or threatened death, serious injury, or sexual violence. You could be doing it directly. You directly experience the trauma, or secondhand, you could have witnessed the trauma. That means you could have also heard about traumatic events occurring to close friends and family, okay? Or you could also actually experience or extreme exposure to traumatic events, especially our colleagues in forensic, especially when you're working in a forensic department, like for example, being exposed to dead bodies, especially after a war, after a catastrophe like a flood, earthquake, people can still get PTSD. So how do they present, So there is one, people either present with intrusive symptoms. Intrusive symptoms, that means they have a lot of dreams, they have a lot of memories of the traumatic event. They can also have a lot of flashbacks, okay, a lot of flashbacks. And because of that, they get very distressed, physiological and psychological distress. And I visited Sri Lanka, okay, after the tsunami, and I spent about 2 weeks doing some psychological work there. And during that time, I saw a lot of PTSD because a lot of people had lost their family, and there were a lot of distinct memories, people who started having flashbacks, memories of their loved ones, I met one patient who basically, because of these memories, every morning she will walk by the beach, because of these memories come back, hoping that, the people that she lost will come back to her, So there were a lot of good for me because it's an experience, but, very distressing for those people who went through it. They also try to avoid a lot of things, like for example, they try to avoid memories and they try to avoid any reminders. I had a patient once, when I saw her, when I was treating her, she was a young girl doing her training. She was a physiotherapist. What happened was one day when she was living in her hostel, her roommate was another physiotherapist, and she didn't know that this roommate had depression and very suicidal. So one day, finished her work, she came back to her room, and when she opened the door, she saw the roommate had hung herself to the fan, and the fan was turning. So she saw roommate's body moving with the fan. And since then, every time she sees a fan moving, she'll start having a lot of intrusive memories, And so because of that, she tries to stay away from fan. Wherever there is a fan, she cannot go, They should sometimes also have negative cognition, Things like, for example, they selectively, sometimes it's an unconscious process, forget or can't remember the traumatic events. It just gets washed off, They try to exaggerate certain feelings, cognitions. They don't have interest like small depressive like features. And many of them have got increased arousal and reactivity, like people who have been through a car trauma accident. Whenever they hear the horn of a car, they jump, they jump and they get shocked. They get shocked very fast. So these are some of the things. The thing is, all these effects start affecting their functioning and they can't work, they can't work, they can't live a normal life. And that's why PTSD is basically a problem. All right. So there's detachment. They can't recall. They always feel bad, negative about the future. They have issues with sleep. They can't concentrate. They have lots of anxiety, sometimes anger, and they're always on high alert, like I just said just now. So what can happen is, because of the severity and the duration, you find that it starts to affect people's functioning. And because of that, a lot of people with PTSD turn to substances because it helps them, especially alcohol, which calms them down, and benzodiazepines. So you find that people with trauma tend to use it. And that's the reason I say always look for trauma in addiction. In addiction, there is a very close link with trauma, post-traumatic events, and substance. And why the substance? Because the substance can numb. When I use the word numb, N-U-M-B, no feeling. So you don't feel anything. They like that kind of a thing. And when you have this link, PTSD and SUD, it's more difficult to treat someone. It's definitely more difficult to treat someone. Okay. All right. I'm moving on to the next one, which is called psychotic disorders. Okay. That means these are people who have got psychotic symptoms. I'm sure you would have seen a lot. You would have heard movies, what you read. What do you understand about psychotic disorders? You say people, we use, previously we used to use the word mad, not thinking okay, all those things. We don't use the term anymore because it's not respectful, But what do you understand by people with psychotic disorders? How are they? Hallucinations, good. Delusions, okay. These are terms that I'd like to hear, yes. Anything else? Have you seen people with psychotic disorders? How are they? How do they behave? How do they talk? How do they dress? How do they think? Many of you work in hospitals. Okay, it's an organic problem. Yep. Find a lot of deviation. Suicides are there. It affects your function. True. Mm-hmm. Okay. All right. So I'm going to put this to a lock. Okay. All right. Yeah. Okay. So yeah, that's basically psychotic disorders. A lot of hallucinations, a lot of delusions. We'll talk about what those are. Okay. These are psychotic symptoms, hallucinations and delusions. Behavior, suicide. It's most of the time organic. It's most of the time organic. Yeah, that's true. Now, can I just ask? What differs us, you and me, from people who have got a psychotic disorder? What is the main difference? Can anyone tell me? Anyone can, what's the main difference between you, me, and someone who has got psychotic problems? What's the main difference?
Psychotic patient doesn't know the reality.
Exactly.
So insight.
Yes. True. That's good. Yeah, that's very good. So, in short, what you are basically saying is they don't have reality. They cannot differentiate what is right from what is wrong, and that is what you call as reality testing. Okay, the ability to tell what's right or what's true from what's wrong is called reality testing. Now, that is what you and me have, and people with psychotic disorders don't have, so they lose it. And psychotic disorders are basically about thinking and perceiving. So these are some of the key features of a psychotic disorder, people with psychotic disorder. Delusions. What are delusions? Delusions are false belief. That means belief about something that is not true. It is normally a very strong belief. So the person holds on to this belief very strongly. So you cannot convince that person, And normally this delusional belief should not be in keeping with the belief of the community. Like for example, I just said Thailand, Myanmar, Malaysia, we believe in ghosts. Some of us have got festivals around ghosts. So the community believes in ghosts, and they believe in some of us believe in reincarnation, believe in ghosts, and sometimes we pray to ghosts. So that's a community belief. So if someone has a strong belief and the community is also believing on the same thing, that is not called a delusion. So a delusion is a strong belief that is not in keeping with the community belief, and it must be false. Okay, it must be false. Hallucinations. Now, hallucinations is a perception. That means hearing, seeing, smelling, tasting, or touching through your sense organ, which is not real. This is like people hear voices. They are alone, nobody around, but they think, or they can hear voices. That's a hallucination. So a hallucination can occur either I hear something abnormal, I see something abnormal, I taste something abnormal, I smell something abnormal, or I touch something abnormal. That's hallucination. Disorganized speech. Okay, disorganized speech is basically people starting to use language which doesn't mean anything. Why it happens is because, remember, I told you it's thinking. Symptoms center on problems of thinking. Over a period of time, your thought gets corrupted and people can't talk properly, and people also can't behave properly. So these are some of the key features of a psychotic disorder. And remember, over time, people who become psychotic can't tell, or they lose reality testing. They can't tell what is true from what is not true. So they start believing in all their experiences, That's where they lose their reality testing, they lose their insight into things. One common type of psychotic disorder is called schizophrenia. Okay? Now, schizophrenia is, there are many types of psychotic disorder. This is the most common, biggest one that you see. It's very chronic. It can be very chronic, and it's a disorder or a disease of the brain. So in schizophrenia, you have delusions, hallucinations. You can also have disorganized thought and behavior over a period of time. Okay. So in schizophrenia, you have positive and you have negative symptoms. Now, what are positive symptoms and what are negative symptoms? Okay, sorry. Positive symptoms are basically symptoms that are added, positive, above and beyond. Negative are taken away. I'll explain a bit more on what it means. Positive symptoms in schizophrenia, they have something called positive. That means symptoms which are above and beyond a normal person. That means they have in excess of what people have. Some examples of positive symptoms are like delusions, the false beliefs, hallucinations, hearing voices, seeing figures, okay? Disorganized thinking and disorganized speech, and also disorganized behavior. These are all positive symptoms. Negative symptoms, okay, as the word says, negative means lesser. That means they behave lesser than the normal person. So a lot of things which are taken away from them. So they are very slow. And how they present is they are very slow, they don't talk much, they have poor social skills, they're always by themselves. Facial expression, very less, what we call as blunted affect or emotions. They don't talk, so they don't even think. There's a very slow thought. They don't express themselves, and they can't start any activity. Is what you call as avolition. So you find that two different types of schizophrenia. The more active one, which is with positive symptom, or what we call as schizophrenia with positive symptoms, or positive schizophrenia, positive type, and we have the negative ones, which are very quiet, they don't do anything. Now, both are damaging to the patient. Because if you have positive symptoms, you'll become very aggressive because you're hearing voices, you're believing in false things. Like for example, some patients believe that the father is trying to kill him, the mother is trying to kill him, so they attack people. They hear voices. Some of my patients hear voices talking to them, telling them things, Another story from the forensic ward, since we have forensic colleagues here with us, okay? I had one client when I was working in the forensic ward. It's a young boy. He was in his 30s, and he had chronic schizophrenia. He used to hear voices talking to him and telling him things. But when he was on medication, voices stopped. What happened was he stopped taking his medication, okay, because he didn't like the side effects, and he was using a lot of weed, cannabis, and that made his psychotic symptoms worse. He started hearing voices telling him to do things. These are called command hallucinations. He lived with his old grandmother, and the grandmother was very old. The grandmother was in her 70s, okay? Grandmother was in the 70s, and the grandmother was old, taking care of him. So the voice told him, "Oh, your grandmother is so old, poor lady. Isn't it nice if she can go to heaven and maybe rest in heaven? Why don't you kill her?" So one day, the voice told him, and he did that. He took a chopper and he chopped her and he killed her, and then he buried her at the back of the house, okay, under a tree. Then the voices didn't stop. The voices said, "Oh, your poor grandmother, she's under the tree all alone. Why don't you get her a partner?" And next door was an old man who lived by himself. The family will visit him once a week. So he went next door and he killed the old man. And then he brought the old man and he put the old man or buried him next to the grandmother, And he didn't run away because, he was not, in his mind, it was not a crime. In his mind, he believed that it was true. That was what he was supposed to do. So nobody knew what happened until the old man's family tried to look for him, couldn't find him. And then they put one and one together, and then they called the police. The police came and searched for him. Police found him, and he was in the house. He didn't run. And the police asked him what happened, and he told them what happened. So when the police dug up, both bodies were there. So he was caught, and he was brought to the hospital. He was sentenced to the forensic ward because he was totally not in a sane mind when he commented, when he actually did those things, So that's how dangerous positive symptoms can be sometimes, you know. Negative symptoms, although you say, oh, they are very negative, they're always staying at home, how dangerous can they be? They may not be dangerous to others, but they are definitely dangerous to themselves. So we had a lot of these patients, especially if your psychotic symptoms starts at an early age. The earlier your symptoms start, the worse prognosis. So a lot of negative symptoms in those patients who start early, and you find that they don't eat, they don't move, you know, everything is just like becoming a small child. So they start damaging themselves. So equally damaging, both symptoms, all right? Now, it starts quite early actually, in the 20s. A bit earlier in males compared to females. Prevalence worldwide, we say it's 1%, although it can range 0.5 to 1.5, okay? Now, very heavy genetic loading. If you have members in the family who are having schizophrenia, your chance is almost 10 times. Very high, okay? Now, let's look at some of the criteria that we have for schizophrenia, and according to DSM-5, okay? It's also one of more damaging disorder and carries huge stigma, schizophrenia. Sorry. Okay, sorry about that delay. Okay. Okay, right. Schizophrenia form and schizophrenia. Right. So the diagnostic criteria is this. All right. So you have 5 criteria: illusion, hallucination. Just now I showed you 4. There's one more. Sorry to add on: organized speech, disorganized behavior, and another one is negative symptoms. So you must have at least 2 or more of the following during a 1-month period. Okay, but the entire disorder should at least last for 6 months. Okay, during 6 months, where you must have at least 2 or more of this going on. It should be actively present for at least 1 month, but the disturbance can go on for at least 6 months. Anything less than 6 months is not schizophrenia. It's something called schizophreniform disorder, something lesser. But the thing is, all this, okay, all these disturbances must cause disturbances and a failure in interpersonal, academic, or occupational functioning. So that's when it becomes schizophrenia. Okay, so that's some of the criteria that you see for schizophrenia. Now, when we talk about schizophrenia, you find that a lot of them actually use substances, at least 50%. The simplest that I told you just now or all along the way was smoking, nicotine, That's one of the simplest things that I have told you. You find that a lot of people with schizophrenia, especially people who have got treatment, use nicotine. Now, you also can find anxiety and depression along with schizophrenia. So whenever you find the presence of anxiety, depression, or SUD, the illness schizophrenia becomes worse. The delusions become worse. Cannabis, as I said, cannabis can also worsen your positive symptoms. By itself, cannabis can cause psychotic symptoms. I think that is something that most of you know. We'll talk about it in the next chapter when we talk about substance-induced psychotic disorder. You know very well that there is something called as cannabis-induced psychotic disorders. All right? So remember that whenever you see symptoms, you have to make sure, are you looking at mental schizophrenia symptoms, or are you looking at substance effects which are covering your symptoms of schizophrenia, And that's very difficult when you have both together. And that's the reason why sometimes we bring them in and we stop substances to see what happens to the symptoms. If it's a COD, co-occurring disorder, remember it's independent. Even if you stop the substances, the schizophrenia symptoms will go on. Okay? Will continue until you treat them. Because some of these substances can mimic schizophrenia symptoms, like cannabis. Cannabis psychosis looks like schizophrenia. LSD, ketamine, okay, bromo-DMA, basically you find that the dissociative drugs can cause a lot of hallucinations, just like schizophrenia. Methamphetamine or any stimulant will also cause a lot of delusion, a lot of hallucination, and it mimics the delusion and hallucination in schizophrenia exactly the same. So it is so difficult to make that difference. All right. Yeah, as I said here, you see, those with schizophrenia, they're addicted to nicotine 3 times compared to the rate of the general population. So it's actually very, very high comparably when you look at people with schizophrenia or any mental disorder compared to people, general population without a mental disorder. So ongoing assessment is very important because we want to see the relationship between the substance and the psychosis. All right. When it comes to case managing, we are not just looking at symptoms. We are not just looking at behavior. We are looking at the psychological and the social effects, because these are a group of more chronic, less functioning people. So we are also looking at nutrition, diet, finance, because a lot of them don't work, people with schizophrenia. And sad to say, a lot of them don't even have house, Sometimes you see them walking around, sitting at roadsides, and many a times they become victims, especially the female patients with schizophrenia, they are brought into sexual or sex businesses, and made victims. So these are things that you've got to be very, very careful about. So as counselors or substance use professionals, you're basically not only looking into treatment and substance use, but you're also fighting for their rights, for the rights of your patients. So be very careful about this. Okay? All right. So I'll be moving from psychosis to something a bit more dynamic, a bit more, well, I don't know how much everyone is aware of it. What do you know about personality disorders? What are they? Personality disorders. You know what personality is, all of us have got a personality, but what is a personality disorder. What do you think it is? Is it good? Is it bad? Why is it called a disorder? Why are there such a thing called personality disorder? What are your thoughts? Type in a few things that come to mind. Dissociative, okay. It's abnormal. It's an abnormal personality, right? That's exactly where my question started. You know, why? It is a double personality, washing members, right? Hand washing, repetitive. Okay. All right. All right. Okay, I'm going to put this to a lock and look at the word cloud. All right. Yeah. So what I see big is I see people writing about, it's something to do with the personality. There's something to do about abnormality. That means it's not normal. It's a bit abnormal. Okay. But there are a lot of other words that people have thrown in, which may or may not actually properly describe personality, Let's talk about personality. Every one of us have got personality. And none of our personalities are the same. You can't be the same like the other person. It'll be different. You may have some similarities, but a major part of it will be different. So there is no such thing as being same. You can't say, oh, my personality and his personality is exactly the same. No. There will be subtle differences, definitely. What decides a personality? Personality is decided by the influences of your environment, of how you grew up, your parents, your growing up period, your community, everything decides your personality. Do you still build your personality after a certain age? Well, the understanding is at the age of 20, roughly, your personality becomes fixed. Then you are who you are. You don't change after that. You don't change after that. So your personality is slowly building during your young, teenage years, adolescence. When it reaches 20, it becomes crystallized. And that's where you are. So with that, personality disorders, are basically traits and behavior patterns which are persistent. That means it goes on. Now, the problem, why they call it disorder, remember I told you, whenever we use the term disorder, it means it affects your functioning. Why is it that this group of people, their personality affects their functioning? It's because they are rigid and they are inflexible. They can't change, They have to do it their way. And the problem is their way is a wrong way, maladaptive. And it causes a lot of problem in their social and occupational function. And some group, even personal. Now, this personality disorder is one of the biggest group that SUD counselors actually see. So they may be having personality disorders or they may have traits. Now, the term traits here means you have certain criteria, but not full to say it's a disorder. So let's say if you need 5 criteria, maybe you have 3, so not enough, but you have a few traits. Just like all of us, we have certain traits, So that's personality disorder. What and why it becomes a problem? It depends on the personality, which we will talk about, Because many of these personalities look at the world in a funny way. They think about, some of them think about themselves, Some of them are too emotional. Some of them are too aggressive, So let's look at the different types of personalities that we have. They are divided into 3 clusters. Okay, cluster A. Cluster A is a group of personality which are odd or eccentric. Eccentric means not normal, a bit funny. One is paranoid personality disorder. Okay, paranoid personality disorder is a group of people who don't believe anyone. They always distrust and have suspicions about others. Remember, they are paranoid, but they are not delusional. Personality disorders are not psychotic. Okay, they are not psychotic because they have reality testing. They know what is right, what is wrong. They know, but they want to believe the wrong. Okay, they want to believe the wrong. So that's paranoid. They're always having suspicion. Schizoid personality disorder. Schizoid don't like social relationship. They always like to restrict themselves. Schizotypal. Okay, schizotypal are a bit eccentric in the way they believe in things and other things. They are basically having a lot of false belief about others. It's not delusions. They know what is right and what is wrong. They just like to be odd. Okay, so the entire group, when you look at them, they are very odd and eccentric. But this kind of group of people rarely use substances. They're a bit odd. They rarely use substances. Now, cluster B. Now, cluster B is where you will see them. This is where most of them end up in treatment because of their substance use pattern. They're either dramatic, very drama, very drama, a lot of emotion, or erratic. One is antisocial. Antisocial are a group of people who don't like to follow rules. Okay? Don't like to follow rules. Borderline. Borderline, more towards females. These are a group of people who are very emotional. They are very impulsive, very unstable. Okay, very unstable. Antisocial, very stable. Very stable, but they don't like to follow rules, Histrionic. Okay, histrionic are people with a lot of drama. A lot of drama. So whenever they are in a group, histrionic people are the people who like to laugh a lot, talk a lot, be the attention of the party, this kind of things. So they try their best to be the attention. If they are not the attention, then they are very problematic. Narcissistic. Narcissistic is a person who likes to praise himself, always praising, talking big about himself, not too bothered about others, The problem that you will not, the group of people that you'll normally see dabbling with substances would be antisocial and the borderline group. There's, of course, the third cluster, which is more anxious and fearful. These are avoidant, people who are not very confident about themselves. They try to avoid. They're a bit more of a social hermit, They don't like people talking negative about them. Dependent. These are people who need to stick to others, like certain wives, they have to stick with husband, something like that. Obsessive compulsive. It's not obsessive compulsive disorder, but it's obsessive compulsive personality disorder. That means they are preoccupied with order, following a pattern, perfection. These are like very perfect people. So perfect that it causes problems to their life, So let's pick out some that are important, okay? Personality disorders, okay? Antisocial and borderline. These are the more common ones that you will see, okay, among your clients entering a treatment center. So when you look at gender, you find that antisocial is more common in men and borderline is more common in women. Okay. Now, let's just have a look at both antisocial and borderline criteria. Okay. You find that this is personality disorders are basically group of people who you would normally see in your practice. But sadly, many of us in practice don't look out for personalities. We miss out a lot of personalities. But it is so important because personalities basically can cause a lot of problems. And I'll talk to you about what problems they can actually cause, okay? So let's talk about let's go to cluster B, antisocial. So antisocial is basically a pervasive pattern, disregard and violation of the rights of others. It's ongoing, okay? So these are some of the examples. They don't like to keep to law, social norm. They like to cheat. You know, they are very impulsive, irritable, aggressive, into the safety of others, very irresponsible, you know, and they lack remorse. When you say lack remorse, that means they don't feel sad for others. They can't feel that. A lot of people think that antisocial are gangsters. No, not exactly. The antisocial person, if I describe it, is a very smart, intelligent person. Many a times, antisocial people are very smart the way they talk, so they can cheat you. These are like, you know, many salesmen have got antisocial. Well, I'm not saying that all salesmen have a personality disorder, but they have traits of antisocial because they're very smart, you know, how they want to sell their things. So they know what to say. They know how to cheat people. They know how to manipulate you. So antisocial personality disordered people are people who are very manipulative in what they say, you know. So, and they always go against law. They like to break the law, you know. And due to that, they always end up in prison. They always get involved with substances, you know. Now, the opposite is borderline. If I say antisocial are a group of smart, intelligent people, and they're very positive about what they do. They know what they want. They're very stable. So they like to cheat. They like to manipulate. They like to bluff. You know, it's not because they're forced into it. They like what they're doing and they enjoy it. That's the thing. You know, they enjoy. They enjoy seeing people lose. They enjoy seeing people suffer. That's antisocial. Borderline, on the other hand, more common in females. It's a very unstable personality. You find that here, they have a lot of abandonment. Many people with borderline usually come up with, have a past history of abuse, either physical or sexual, because they've got a huge problem with relationships. They cannot make or confirm relationships because the trust is not there. And they also have identity disturbances. And because of that, sometimes they're very impulsive. They harm themselves by self-harm, cutting, maybe driving fast, eating fast, you know. And sometimes you can find suicidal behaviors also. You can find suicidal behaviors also. Because of all this, they are very unstable. You find that their mood is also up and down. So they can have mood instability, sometimes anxiety, depression, emptiness, you know. So they can end up with depression and mental health problems. And because of all this, they tend to use substances to numb themselves or to cover up some of their symptoms. Okay, so that's what you normally see in antisocial and borderline. So let's talk about antisocial and SUD. Sometimes it's so difficult when you want to differentiate whether it's the effect of the substance or is it the personality disorder. Because even people who use substance present with a lot of antisocial, you know, especially hurting, dishonesty, illegal, So there's a lot of overlapping of symptoms. So the suggestion here is you have to remember that people who have borderline, who have antisocial, it's personality, it's part of themselves, So they're not doing it because they're planning to do it, but it's how they grew into it's the disorder, it's an illness. They are manipulative, so be aware of it. Okay, be aware of it. So don't get cheated. So a lot of people get cheated in treatment. You find that these are the group of people. If you find it, you find it quite common in a treatment center. These are the group of people who start a fight. They start the problem, but then when the problem is big, they move and they run away. So other people get scolding, but they don't get scolding. They're very smart people. But knowing that you must build a trusting relationship, but have that boundary. Don't cross the boundary because you can get manipulated. So the goal here is therapeutic alliance. The empathy and the active listening builds a lot. As much as you listen to them, be careful about the boundaries and don't get manipulated yourself. All right. Borderline is a bit different. Now, borderline have got huge problems with relationship, self-image, and emotions. More in women, you see. Like I said, they have, because of the way they have grown up, they have two things which is called idealization and devaluation. So much so that sometimes when they look at positive, they exaggerate too much. Or when they look at devaluation, negative ones, they exaggerate the value. So there's also something that is called as the all or none law. Okay, all or none law. So you find that it's either they believe that a person is good 100% or a person is bad 100%. So if they think a person is good 100%, they will get very close to the person until they find something wrong. Then the person becomes 100% bad. Then they break away. So you find that they never get close to people. They can't maintain relationships. A huge thing, a huge problem that they have actually. Because of that, they sort of use a lot of substances to overcome tension, to overcome their mood symptoms, and they are very easily influenced by others. Just the opposite. Antisocial influences others. People borderline by others, So they use substances whenever they need it, like when the mood is low, when they, after a breakup, then they use substances to calm themselves. So they don't have a magic drug or a drug of choice, whatever helps them. But many of them use it because it sort of calms them down. All right. So that's basically a personality disorder. All right. Now I'm just going to finish up one before I stop for some questions. Okay. And this is basically ADHD. Okay. And children. Well, I'm sure you would have seen ADHD. Okay. What do you understand by ADHD? Attention deficit hyperactive disorder. You must have seen kids with ADHD symptoms. What do you understand by ADHD? How are they? Are the kids? What are the problems that they have? Yep, short focus, hyperactive. Right? Okay. Okay. So I'm going to lock this thing. Right. So I've locked it. So let's have a look at this, right? So yeah, attention is a big issue here. It's short. Okay. Yeah, it can work in autism, but there's another issue. It's not just attention. It's also hyperactivity. And focus is a huge problem because they can't concentrate much. Now, we don't, we most probably don't see a big number as patients around this region as we do in overseas and Europe and US. It's not because there's more ADHD there. No, it's may also be because of the low detection rate that we have, you know. But when you talk about American statistics, you find that the numbers are quite big. 11% of kids aged 4 to 17, and that's quite huge numbers, you know. They have always said that the rates are greater among the boys, you know, compared to the girls. And if you had a diagnosis of ADHD, obviously it comes with problems, you know, problems in terms of development, problems in terms of academic and social functioning. And it's said to be at least 10 times compared to those kids without ADHD. All right. Now, what happens in ADHD is there is always a link of ADHD with other disorders. Especially, there is a close link between ADHD and something called conduct disorders. Conduct disorder is a disorder in children where they have behavioral problems, you know, where they have behavioral problems and where there's a lot of breaking of law, not listening to people, a lack of empathy, and that has also a close connection to antisocial. So people are wondering whether there is a link between ADHD, conduct disorder, and antisocial, you know, and whether it makes a child at a higher risk to actually have antisocial. We have seen that, you know, where kids with ADHD are more prone for conduct and eventually go on to have antisocial, but not necessary at all. Now, what happens in ADHD? You know, you find that how ADHD kids are. As a young child, you may find a lot of hyperactivity where they can't sit in one place. You know, they're always running around. So the teachers will always say, "Oh, this fellow cannot sit in one place, you know. He's always running. Instead of his own class, he'll be sitting in the next class, in the canteen, running around, can't concentrate, you know. Even if they're sitting, they can't focus because a lot of inattentiveness. And because of that hyperactivity, some of these kids get into problem. They fight with each other, you know, because too much of energy. But what happens is, you know, sometime in their growing up period, let's say early teenage years, adolescence, at the age of 12, you find that the hyperactivity comes down. But the attentive disorder goes on, you know, it goes on. So it starts from young, but it continues after adulthood as an attention deficit disorder, where they find that they can't focus too much of thoughts. When they sit down to do one work, they're thinking of 1,001 things. So they find it difficult to focus. So their work becomes slow. Something that can be finished in 5 minutes takes half an hour. Something that can be done easily, they take many days, or they procrastinate, and they can't multitask. You know, they can't multitask. So ADHD has got criteria of their own, you know, where they look into different aspects of a child, which I said has to start, you know. Submit. Okay. So when you look at the ADHD criteria, you're talking of symptoms of inattentiveness and or hyperactive impulsive. So inattentiveness, you have few criterias where can't give attention, sustaining attention in problem, cannot listen when spoken to, cannot follow through instructions, difficulty in organizing task, cannot engage in task, losing things in activity, very easily distracted and forgetful, hyperactivity, very fidgety, can't sit in one place, leaves the seat, always running, climbing, unable to play or engage with other kids quietly, always, is often on the go, as though driven by a motor, cannot stop. Always talking, cannot stop. Before you can even ask a question, you're answering other people's question, can't wait for his or her turn and interrupts. So these are the things that must be present prior to 12 years. Start when you're young. These are the criteria. So people can't have ADHD from after the age of 12. It must have started earlier, but it can go on. It can go on after the age of 12. It must have started earlier. That's the thing. So you find that because of their inattentiveness, they turn to substances. Okay, they turn to substances. And a lot of adults have got alcohol dependence. And some of the youngsters, as I said, use a lot of stimulants because stimulants help them focus, helps them focus. How does it complicate? It complicates the treatment because it's more difficult to engage in treatment, They cannot learn abstinence skills. They basically have a greater risk for relapse. And of course, in terms of substance use, the outcomes are poorer because they always see substances as a positive thing to control their symptoms, all right? To control their symptoms. So suggested things here is make sure that you look out for ADHD because it can be there. Many cases of ADHD have been missed as a child. In my practice, we've picked off some as an adult, but when you look back into their past, they will tell you that as a child, they were always very active, always cannot study, always fail exam, very disruptive, but nobody has picked it up until they became adults. And then they're having problems, Many people we have picked up are from high school, college, university, but you find that it started earlier. Nobody has picked up. So there are proper treatments for ADHD. There are medications, okay? But what you can do is, in your practice, because these are people who find it very difficult to concentrate for long. So don't have long meetings. Like, this kind of meeting is a bit too long. Like any one of you with ADHD, maybe you wouldn't be sitting in your chair. You'd be walking up and down, So keep it short. If you're going to talk to them, meeting, counseling sessions, keep it short, Don't talk too much because you can't concentrate. Show them pictures. Show them visual this thing, And use a lot of organizational tools like writing down journal, schedules, color, This helps with their attention. Okay? This helps with their attention. All right. Okay. So I am going to stop here for some doubts or questions. Do I have any questions? Any doubts on, we've covered psychotic disorder, personality, and ADHD. Any doubts on that?
Hello, Sam. Okay, can you share your experience in distinguishing truth and false insanity? Some people pretend to be insane to avoid criminal punishment. So, what are the main points to differentiate truth and false?
Insanity. Okay, right. Okay. That needs a proper examination. So we're talking about forensic. Okay, we're talking about forensic things. Like for example, true and false insanity. Like someone who's done a crime, and then say, "Oh, I was unwell. I was unwell at that point, and that's why I did this." So how are you going to determine? That was the question. How are you going to determine whether what this chap is saying is true or false? Now, one is consistent symptoms. Okay, consistent symptoms. So if a person says that he or she experiences psychotic symptoms or mental health symptoms, if it's there, it must be consistent. And that's why sometimes in the forensic wards, I suppose in Thailand, it's also the same. In forensic wards, psychiatry forensic wards, we have CCTV. We have CCTV and we are watching clients every time. We are watching clients every time. So it should be consistent. If a person is consistently presenting symptoms, then it's most probably true. But cameras can catch you off guard sometimes. And sometimes interviews that you do consistently, you will get different answers if it is not true. So that is one. Two, you need collaborative information, about medication, about functioning. Like, for example, the case that I told you about the man who raped and murdered his sister-in-law. So one thought that we were thinking, is he bluffing? Okay, is he bluffing? But in the wards, he was manic. And when we watch camera, we could see him every time. He was manic, the way he acted, the way he talked. So it took him at least 2 weeks plus for his mania to come down on treatment. Consistent symptoms. When we got information, we went to the place where he stayed. We checked the hospital. And clear enough, the records show he already stopped his medication more than a month. So he was not taking medication. One. Two, we started speaking to neighbors, getting more information. And the neighbors also agreed, yes, he was walking around, shouting, not wearing shirt, So there was clear signs of psychotic behavior. Number three, we spoke to his employers. So the employers also said that at work, he couldn't function because he was fighting with others. So they sent him off. They stopped him from work. So how do you determine? You have to determine not only by talking and observing, but you need other collaborative information from others. Family can, but sometimes family will always support the client. So you got to ask neutral people. So that is what we did. Records from the hospital, information from the neighbors, information from the employers, and then you put it together and then you come up with your conclusion. So I think that is the best that you can actually do.
Okay, thank you very much, sir.
So it's like a small investigation, like a small CSI investigation. All right. So forensic is actually very important, very interesting and important. Forensic and also forensic psychiatry. Any other doubts, questions?
กดเลยดัง
Hello.
Hello,
I have one question.
Sure.
I would like to know how do you to handle antisocial if you do group like that,
I
group that addict like that, and or in your group about to handle an antisocial when you see.
no, I sorry, I didn't get the question. Come again. How do you?
I would like to know how do you to handle an antisocial
in the group counseling.
in the group counseling.
How do you handle what in group counseling?
Antisocial.
Antisocial.
Yes, antisocial.
I normally we don't bring we try not try we bring it antisocial. Yeah.
เข้ามาไม่เอาเข้าตั้งแต่แรกดีเทคตั้งแต่แรก
We try our best once identified. We try our best not to bring in antisocial into a group. That's a very good question. Because as much as you want, if you bring in a person with an antisocial personality, your group will go haywire. Your group will go haywire, and you will be fighting fires. You'll be trying to solve problems than anything else. So many counselors would choose to handle antisocial personalities with one-to-one or individual counseling. But there are some special groups for antisocial. In those groups, we only keep people with antisocial personality together. So it's only people with antisocial. So we don't mix them with others. And that is a very special group handled by special counselors trained in personality disorders. A very structured one. So you got to be very careful. Not advised to mix a person with antisocial personality in another group. It's going to be trouble.
Okay. Thank you. But I work with about that addict, and them have many kind of like that antisocial about behavior to do go like that. You understand? Yes.
Can you repeat that again? Sorry.
Like we do about group with that addict. He will have some personality to an antisocial to when smoking like that. If I talk to him about what do you think about that youth that like that, he will have a positive thinking like it's good for me. I don't want to come to quit that like that. He not like to walk to come to quit that. Yes. And when I talk with him, I will have some emotion, angry like that. Why you don't think like that? Why? Yes. You understand? Thank you.
You're talking about an experience. It's your real group, is it?
ฟังเขาด้วยดิเนาะ
Are you talking?
คุณบอกประสบการณ์ใช่ไหม
Your
ก็มีคนที่ค้านอยู่ตลอด
okay. And what emotions do you have against him? What is your emotion?
He don't understand and don't agree with me. He will look good for you that don't. But I want to change my about thinking for automatic like that with them about. I want to him to good not look Sam every time to see about or want to use that. I want to him have change thinking about that when him see, but him have only positive, only good thing about to use, but not have negative or bad thing about that like that. And when he come to in the book, he will have idea for him and another see don't think like counselor or to come to treatment like that. Yes.
Have you had problems when he was in the group? Any problems that he caused?
It hard to talk.
He can't?
It hard to counselor. It hard to help him. Yes.
Okay. Sometimes if he's already in a group, if you already put him in a group, then sometimes what people with antisocial personality like to, they basically like to lead. They like to be given responsibility. They like to basically do things. So some ways of trying to help him or give him this thing is to give him some amount of responsibility in a group, but limited responsibility, not too much, limited responsibility, which is very structured. This is what people with personality disorders need. They need a structure. That means, yes, you give them responsibility. You cannot push them away, You push them away, the more they want to fight. You have to give them some responsibility, but structured. You can do this, but you cannot do this. Very structured in your this thing. So let's say in a group, okay? Let's say if you are giving a person, just a small example, you're giving a person 5 minutes to talk. 5 minutes. So you cannot manipulate more than that. You cannot go on to 10 minutes, 10 minutes. No. You must keep to structure. So if you're bringing in a person with an antisocial personality, you must make sure that your group session is very structured.
Thank you. Thank you.
Yeah.
Okay. Thank you.
Okay. Now we will stop at 12:45. Okay. We will stop at 12:45 to break for lunch. But now, what I'm going to do is, I have put on the chat, okay? I put on the chat a few tasks, okay? So you find that group 1 is going to do a case study on mood disorders. Group 2 is going to do a case study on anxiety. Group 3 will be doing on personality. And group 4 will be doing on childhood and adolescent disorders. Okay. Now, it is all in your resources, in your books. I've also put the resource page or the resource number. So it will be on your handbook. You all have your handbook, right? Right? Yeah, the books that you have in front of you.
Yes.
Yeah.
Yes.
So what you can do, okay, what you can do is under each of your groups, I also put a link. The link is to your Padlet. The link is to your Padlet. That means it's back to this. When you press the link, you'll get this. And as you're writing, so because we are not doing it physically, so what I'd like you to do is I'd like you to write down your findings here. So you can basically use this as a desktop. You can basically use this as a desktop and write down your findings here. So you can also basically just put it down here, and you can even put pictures if you want, or you can write. You can also expect it to be long, or put it short and keep it there as a desktop. So as you're writing this on your different things, group 3 and group 4, I will be able to see, okay? I'll be able to see what you're writing. And you can be broken into groups. Can we break them into groups also? Dr. Chisu?
Yes, I'll break into 4 groups.
Yes. Okay. So you can work within your groups, And as you write in, you can also this thing. So you've got about half an hour or so before we break for lunch. And then after lunch, when we come back, make sure each group picks one person to present. Okay? One person to present. So what you have is you have a case history. And what I want you to do is I want you to talk about diagnosis. Okay? I want you to talk about how you're going to manage. Okay? So from the history, the case history, I want you to talk about what are the diagnosis, what are the management that you're going to do, and the problems that you may face as a counselor. As a counselor. 3 things. Is that clear?
Yes, Professor.
Yes, Professor, the assignment is very clear. But what I want to know is, you want breakout sessions now, or?
Yeah, because we are only stopping for lunch at 12:45.
Yes. Okay. So after breakout sessions for presentation, the presentation is before or after lunch?
After lunch?
Okay. Right. So we will take a break at 12:45, and before that we will do some breakout sessions, and after the lunch we will do presentation, right?
Yes. After the lunch, we will come back at 1:45, and then we do our small group. Each group presents after lunch.
Okay.
At 1:45.
Professor. So I will break into groups. So please make sure to copy the link. So in group 1 there will be health department account and Adhd Chai, right? Group 1. So please copy your link. And for group 2, it will be me, Dr. Ong Po Mie and Dr. Teng Lin Ao. So our 3 of us group 2. So please copy the link, Dr. Teng Lin Ao and Dr. Ong Po Mie. And in group 3, Dr. Agahe, Chan Yin and Dr. Demao Lai. So please copy your link. And in group 4, there will be Dr. Natisha, Ajahn Supapek, and Ajahn Suti and Ajahn Thiru. I'm sorry, I cannot pronounce. And Ajahn Donchai. Sorry, Ajahn Donchai is in group 1. Sorry. So these 4 are in group 4. Is that clear?
Yeah, and about the rest of our BMA will be in group 1.
Yes. About the rest, who is left? Like Dr. Lolita, I think it will be in group 1. So anybody left in my list? Everybody included? Everybody has a group now?
เราได้กลุ่มกันครบยังคะ
How can I move around, Dr.
All right, Professor, I will make you the co-host so that you can move and you can leave and enter all the groups. I'll make you the co-host. Right, I will make you now.
Okay.
Now you are the co-host.
All right.
Okay, so please copy your link. In a minute, I will do breakout sessions. Thank you.
I don't think the co-host can move. Can it? Can he or she?
Yes, I think co-host can move because I'm doing now the breakout sessions now. So please wait for a few minutes.
Right. Okay. Because I can't see the breakout sessions on my screen. Yep, now I can. Okay, so those of you who already have your assignments, please get into your breakout rooms and work among yourselves.
Dr. Chisu, I can find results page 1.45. What is it?
One, no,
4.15. Sorry.
4.15. 4.15, sorry. Is it there?
Is this from course book 4?
Yeah. It's on the resource page 4.1. Oh, sorry, wait. Let me just check. Yeah, 4.15 is infancy, early childhood, and adolescence. Is it there?
Dr. Aga, can you find? Because I'll start the session. Can you find now?
Still looking for it.
Okay.
Participant manual, right?
Yeah.
Okay.
4.15. Okay.
Is it there? Yeah, I think while we are searching, we can start, I think.
Oh.
cô Thiênအောင်လေ
အေး
အကိုညီမနဲ့အကိုနေက group 2
မဟုတ်ဒီမှာမပေါ်လာလို့စောင့်တာ
အော်ဟုတ်လားခဏလေးနော်အကိုအဲ့ဆိုဟုတ်ထဲဝကြံလိုက်ကြံခဲ့လားမသိဘူးခဏလေးနော်အကို
ရတယ်
အကို join လေးမရမထင်နဲ့အကယ်တော့အကိုက session နဲ့လာသီလား join ကိုမနှိပ်ပြလိုက်ပြီလားအကိုညီမဟိုဟာလေဘယ်လိုလုပ်ပေးရမလဲမသိဘူးအကိုညီမနေတော့ထည့်ပေးမယ်ခဏလေးနော်အကို
This is which group actually?
This is the main room, Professor.
Okay.
Because some are left. That's why I try to call them.
Okay. All right. All right. Okay. Fine. They have found their resource page, right, Dr. Su?
I hope, Professor. I'm not sure.
Naman, I'll move and ask. Okay. Dr. Lalita? Hello? All right, everyone. I think while we work on this, we will take a break, okay? And return at 2 p.m. All right. So
Okay.
try your best to just finish up whatever you can before we meet. So at 2 p.m., I think we'll have 3 groups that will present. Please pick your presenter so he can get ready by 2 p.m. I think there was a problem with the case. If we can find a case, but I'm not too sure. Dr. Supapa, did you find it? No, right?
No, not yet, because I trying to look at in the participant manual to share among in the whole group, but it's the same version.
Okay.
Again, it is in the participant manual 3 because confused. This is a day 4, but the case are participant manual 3.
Yeah, I look at in the 3.
And it is around page 227, 228. Around that, the cases are. So it will be better to find because 4.10 is a bit difficult to find. I think you may find with the page number.
Okay.
7, right?
It is,
Can you have it with you, Dr.
Yes. You are the case 4, so the case 4
So it's under module 3, is it?
It is under module 3. Yes, it is UTC 3 participant manual, not 4.
Okay. Oh yeah, it is UTC 3 actually.
That's why I was confused before. Me too.
Oh, when you saw 4.13, you thought module 4, is it? UTC 4, is that what the confusion was?
No, I look at the UTC 3, but I couldn't find. I think it's upper, like Paul, right? Paul is the case study.
Okay, yeah. You have you found it, Dr. Baba?
Yeah, I found it. But my case would be like after schizophrenia.
Yeah, your case would be after the ADHD.
Okay, after the ADHD.
What do you see after ADHD? What case? You will have a whole range of case studies.
Karen, right?
Okay. You have Karin?
Oh no, Karen is ADHD. After that?
Yeah. After Karin?
Module 4.
After Karin, do you have another small group exercise? No?
No, it's just start with the module 4.
Okay, then why don't would you be happy to do Karin?
Sure.
Okay, right.
But I don't
actually I'm sorry.
Yes.
Yeah.
Anyone do the Karen?
Yeah, you can do Karin. No problem.
No. The case study for ADHD is Lina. Is that?
If you don't have that, Lina, Lina.
Yes, I have.
If you have Lina, yes, do Lina.
Okay.
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 Professor,
Thank you.
yes. Professor, I have a question because for me, mine is the group 2. So according to your assignment, you assign case 4.9 as an anxiety disorder, but in the resource paper, the case 4.9 is not an anxiety disorder; it is panic disorder. So it's okay to for me to do that case because it's not anxiety.
What's the name of the patient?
Excuse me. Geeta, Geeta.
Yeah, it's okay. No problems.
Okay, so we'll do that. Okay,
yeah.
Thank you.
Okay, we will meet at 2 p.m. I think you can take that break and we can break for lunch.
Okay, thank you.
All right, thank you.